In the last 9 years, I have sadly gone to a lot of funerals of patients who I have gotten to know, and they rely on the patient organization because no one really understands this, right? They rely on us because we understand the disease, and they were grasping for some type of treatment and couldn't get it. And then when it finally became available, they were so sick or already listed for transplant that they wouldn't benefit from it. This is why I can't stress early detection and access to therapy as soon as possible for Canadian patients. I really hope that that's the takeaway from today.
Welcome to the Expand podcast, where we unlock the secrets of respiratory health for healthcare professionals. Join leading experts as we dive into chronic lung diseases and expand your practice.
And I'd like to welcome you to this podcast, a new episode of an important healthcare problem related to chronic airway disease such as COPD, asthma, bronchiectasis. There is a genetic condition that is called the deficiency in Alpha-1 Antitrypsin, and that's what we're going to talk about. We have the privilege of having Angela Diano, who is the Executive Director of AlphaNet Canada. This is an organization that has been dedicated to ensuring equitable access to testing, treatment, and support for those affected in this genetic condition of Alpha-1 Antitrypsin Deficiency. There are many challenges, and we're ahead now of a change that had started to happen in terms of access to the treatment. And this is what we're going to talk about, the journey that Angela is going to take us through. That how did we get to that point, and how can we continue to make a change for these patients? Thank you, and welcome to everyone. I'd like to welcome you to this podcast on Alpha-1 Antitrypsin Deficiency. And we're going to talk about lung disease here, chronic airway disease, and you may have heard some of these diseases like asthma, COPD, bronchiectasis. We're very lucky. We have with us Angela Diano. She's the Executive Director of AlphaNet Canada. Thanks for being with us, Angela. And maybe I'll ask you just to tell us about yourself to start this podcast.
Absolutely. Well, thank you for inviting me to join you today, Jean. The focus of my career has been in patient advocacy. I am not a clinician. I focus on finding pathways to ensure equitable access to care and treatment for all Canadian patients. I actually had the pleasure of meeting you for the first time in 2016 at an Alpha-1 patient education event. I was only 2 weeks into my role at that time. Yes, that was 9 years ago.
Been a long journey. I know it's been a long, we're going to talk about your journey, but it's been a long journey.
It has been a long journey, but we have made some significant progress, which I'm sure we'll get into. And then as of recently, November 2024, I merged Alpha-1 Canada with AlphaNet Canada, simply to broaden our advocacy and our disease management services. So we have more of a team now rather than just one.
This is great. And but first of all, we're talking of a disease, and there are other examples of disease. But what about one person that not alone, but that person can make a difference? And what we can do together that we cannot do alone? And that then we're thinking about what are we trying to achieve here in terms of that disease, where we want patient to be better or we want patient to have access to a treatment. We're going to talk about that. You're a champion, Angela. I know that. Okay, I've been following you. We wouldn't be where we are with the treatment of Alpha-1 Antitrypsin Deficiency in those patients that have this disease, terrible disease, that the end result is a lung transplant, and that's what we want to obviously avoid. But tell me about Alpha-1 Antitrypsin. What does it mean for the public and the patient out there?
Sure. Well, Alpha-1, it is a genetic disease, and it affects the lungs and or liver. It is a progressive condition, which can lead to serious lung and or liver disease. And left untreated, just like you said, may result in a transplant. And sadly, in my 9 years of doing this, premature death. And we have seen a lot of patients, unfortunately, die prematurely because they lived in areas of the country where they could not get access to treatment. And sadly, were often diagnosed late, very late. In simple terms, again, I'm not a clinician, Alpha-1 antitrypsin is a protein. It's made in our livers and it travels through our bloodstream and to help protect our lungs. So without it, there's a gradual destruction in the lungs. And if you don't have that protection, things like smoking and even environmental pollutants can easily damage the lungs. Unlike someone who does not have an alpha-1 deficiency, they have that protection. Can they still have lung infections and other lung diseases? Absolutely. But with a severe alpha-1 deficiency, there's little to no protection.
Yeah.
So
and the problem we have is it's not giving a specific disease. And for a very long time, people were looking for very specific feature. The patient has 40 years old or less. The patient has this type of emphysema. The patient has, and then it is in the sea, the ocean of a disease that is very common, such as COPD, even asthma, or even some patient that may have bronchiectasis. That makes things very, very confusing and difficult in that sense.
It's very confusing because if you have alpha-1, but you were a smoker, for example, and you have shared with your physician that you were a smoker, whether it was 5 years or 25 years, regardless, and you have developed COPD, okay, well, you have COPD, you were a smoker, and that's it.
Stop the smoke.
Right. And it's not until several years, and we see this, not with a few, with hundreds and hundreds of patients across this country who were never tested for alpha-1 because they were told they had COPD or asthma. And it wasn't until they finally saw a respirologist knowledgeable that did an alpha-1 blood test.
I like that. Yeah. What do you mean by knowledgeable?
Well, I can get pretty cynical.
There's something behind that I want to know. What do you mean?
You know, it's hard not to be cynical at this stage in the game because testing for alpha-1 is very simple. It cannot be done by a medical examination alone. It is a simple blood test. So it is very frustrating that more patients aren't being tested as well. I'm sure, I think we're at 2 million Canadians living with COPD, roughly.
Yeah.
So, and absolutely. We know roughly that 3% of patients with COPD have undetected alpha-1. And these are patients that can go on until, their 60s and 70s thinking that they had something else when they could have been treated with an alpha-1 replacement therapy decades before. So awareness is crucial. This is considered a rare disease. I am also a little cynical about that because I think rare disease are rarely diagnosed.
I'd like the second one. I think the second one would be more appropriate.
I agree.
Because people would like to know that the prevalence of this is more than cystic fibrosis.
Yes, it is.
Therefore, it is kind of what you say, why come I know so much? Everyone have heard about this. Maybe, there are children, where this is adult and many of them are smoker, then there's still this stigma. But awareness, you pick on the point here that is the most important. It's awareness. Awareness of the public, awareness of the healthcare professional, then in the medical community. And a change not only of knowledge, but change our belief. And this is what we would like to bring people to kind of change their belief. But beside that, it's doing the test. And I think you've expressed that very clearly. This is a blood test. We're doing tons of blood tests, many that we repeat, many that we could even question. We're talking of doing a blood test to the right, patient. The new CTS guideline has just been, it's online, and what is this guideline have changed in terms of testing or early diagnosis that you would like to highlight, to the medical community and to the public?
Again, feel free to interrupt me at any time. I'm very passionate about now having a new tool in the toolbox, which are the new CTS guidelines. And we've been waiting many years for this.
I know that. We were talking about that in 2016. Do you remember?
We were.
Angela?
We were.
You remember?
Yes, and they were.
It's coming. I was telling you, it's coming.
It's coming.
I was right. You know.
Well, yeah.
2025.
COVID was a big speed bump in that happening.
Yeah.
So I'm very happy that in 2025 we finally have them, because it is a resource for healthcare professionals, especially. Many physicians, especially those who are practicing in rural and remote areas, may only see one or two alpha patients. They think, right? But I often say there's no one alpha in a family. This is a genetic disease. So you think you only have one alpha in your practice, but has that healthcare professional spoken to the patient about the importance of family screening and what that looks like? But there is a stigma that comes with that, right? And because we're attaching terms like COPD and emphysema to Alpha-1, we're only reinforcing that stigma. So I'm happy to have the guidelines to kind of break down those barriers and make the direction for clinicians very succinct. This is the steps that you need to take, and this is who should be screened. And I think that is important. In fairness to physicians, they're all at capacity, and there's over 7,000 rare diseases. So how could they possibly know about everything, right? So I do understand that the healthcare professionals are at capacity. However, this goes back to our comments about a simple blood test, even just to rule it out.
Yeah, exactly.
And I think the guidelines do a great job at addressing that. And for the first time, the guidelines also support access to augmentation therapy, which, again, there is no cure for Alpha-1. I want to be very clear about that. But there is treatment that can slow or halt disease progression. And I think...
What is augmentation therapy, Angela? Because
yes, let's get into that.
And maybe people don't, we'll
Absolutely.
get to we've been talking of an early diagnosis. We've been talking of recognizing which group of patient. Then the test is a blood test. It's easy to do, relatively cheap.
Very.
And then obviously if that test there is low value in that test, or you're questioning the value of the test, then you refer the patient to a respirologist, like you'll do for referring to an endocrinologist, or referring to a cardiologist, referring to, then there is a treatment, because if you don't treat, these people have accelerated damage to their lung that we call emphysema. This is the umbrella term is COPD, chronic obstructive pulmonary disease. And there is accelerated decline in the lung function. Obviously, if you're a smoker, more, but you don't have to be a smoker to have that.
Absolutely not. I mean, the majority of patients that I speak to, actually, especially those younger, 50 and younger, they were never smokers. So that's why they're so confused when they get a diagnosis like emphysema, and they think that's something my grandparents had. How could I have emphysema, right?
Yeah, having smoking.
Right. So the Alpha-1, again, no cure, but it goes back to my earlier comment about a protein. So when the liver is not producing that Alpha-1 protein, providing a sufficient amount of protection to the lungs, so the protein is traveling through the bloodstream. If it's not there, that gradual destruction is happening. And to your point, if someone is working carpentry, oil and gas, anything with around more pollutants, that destruction is accelerated, right?
It's accelerated.
And the more the deficiency, the more it is accelerated. So the goal is to replace that protein, that Alpha-1 protein that individual is not getting in their blood system. And that is done through a weekly infusion of an Alpha-1 protein. We refer to it as augmentation therapy. It is also referred to as a replacement therapy, because we're replacing the Alpha-1 protein that the individual's body is not delivering to their system. In Canada, we have 3 therapies approved by Health Canada. We have Zemera, Prolastin C, and Glacia have all been approved by Health Canada. And currently, patients in the province of Quebec can access Prolastin, and
Okay.
Canadians and the rest of the country, as of 2024, can finally access Glacia through Canadian Blood Services. And again, it is to augment the missing alpha-1 protein, which is why we call it an augmentation therapy.
But that's a blood product.
It is a blood product. It is a blood product.
But there is a company that is, because they have access. How do they have access? Okay, because this is not a human-made product.
Well, it's augmentation therapy is an alpha-1 protein collected from donors, plasma donors. It is then fractionated, the plasma that is collected from a plasma donor, and the proteins are pulled out to treat various
Condition.
So the alpha-1 protein is fractionated, and then depending on a patient's body weight and what their needs are, it would be a weekly infusion of the alpha-1 protein. Again, several brands have been approved in Canada. And that is a plasma-derived product. It is not something made on a conveyor belt. It's not something you can't go and pick it up.
It's not a drug. No. Yeah, it's not a drug made by a company. Yeah.
Well, they're fractionated by a manufacturer, and they are currently distributed outside of Quebec through Canadian Blood Services because it is a blood product. Now, what happened before 2024 was this debate among all of our provincial and territorial governments outside of Quebec and BC to some extent. They did not understand the value that augmentation therapy provided a patient. And again, this goes back to your earlier comment around the stigma of emphysema in COPD. That stigma exists also with decision makers in our healthcare system. When a patient,
absolutely
right, they consider that is a lifestyle disease, right?
Disease, more that you choose. As opposed to, I have a disease that I didn't choose. And this is where guidelines are very important. Okay, and the Canadian Thoracic Society has played a major role, but I'm going to get to you in a minute, by providing the evidence. And it took a while to change the even physician mind that, we have the evidence to show that there is an effective treatment. But in the previous guideline, despite a study such as the RAPID trial that was done, and this goes almost back 10 years ago. Can you imagine?
Yes.
It took a decade. Okay, you worked during that decade. That was the evidence on the top of some earlier evidence of pooling two small randomized clinical trials. And we're 10 years later. But what kind of a battle did you do during that last decade to convince government across the country? Because we were talking of equity earlier on in terms of patient being in different part of the country or within the province of territory. But there was a lot of iniquity between provinces also.
The province, British Columbia, did provide access to Alpha-1 patients who had to reside in British Columbia. So many Canadians diagnosed with severe Alpha-1 Antitrypsin Deficiency had two choices: either wait to be listed for transplant, die prematurely, or move to British Columbia to get on treatment. And many did. Many people uprooted their lives, their careers, their families, left their communities to move to BC to get on treatment. Some moved to Quebec, where there was also and continues to be access to treatment. A little more challenging to get approved through RAMQ in Quebec, but not impossible. That being said, the rest of the country didn't have access. They did not. And if they did have access, they had to have excellent employer-sponsored insurance. And even then, there's always annual renewals, which if a patient fell below a certain lung function number, they would be cut off. And if they retired or left their job, they lost their insurance. So they would see how well they were doing for 5-10 years on treatment, and they'd have either forced retirement, and you lose your coverage, and then they decline. So it was very confusing when I joined Alpha-1 Canada in 2016. I was still trying to understand, what is the debate about this? It's quite simple. Missing protein, let's replace it.
I like that.
Improve quality of life. A, B, C.
I like the way you're putting that. Yeah.
Right? So, and why we do this for blood disorders, right? Where there is a deficiency in a protein, there are replacement therapies. We don't say to someone with a primary immune deficiency, a sickle cell patient, anyone that requires a blood therapy, we don't say, well, we're not sure.
Wow.
We don't do that. It is, the therapy is provided to them. So in 2017, I presented to the Canadian Blood Services Board of Directors, and Canadian Blood Services is not a government agency. They are funded by all of the provinces and territories. So they are not the final arbitrators of any decision. You have to get all of the provinces and territories outside of Quebec, because they have their own health system.
Quebec has their own, yeah.
So I have to get 12 governments to all come to a consensus.
Gosh.
And they thought, well, I was told, if you could do that, then of course we could list augmentation therapy with our other plasma-derived products, because they have their own formulary, which would mean equitable access, whether you're in St. John, New Brunswick, or Red Deer, Alberta, It doesn't matter. So
because people have to know, Angela, just correct me if I'm wrong, but what you're saying, people have to know that these products that we had access were not coming from blood derivative here in Canada. They were coming from outside. It was still very safe, was very well, but it wasn't coming what you're talking about now, and say, well, we have all these blood, that are, and part of the plasma and the blood that are used for many diseases, but not for this disease here in Canada.
No, we do not fractionate plasma in Canada yet. But no, historically, we don't make anything here. So all of the plasma and blood products we are bringing into Canada are high-cost therapies. So we know that it takes over 900 plasma donations to treat one Alpha-1 patient for 1 year. It's very costly. So the therapy ranged, again, depending on how much replacement therapy a patient needed, between $110,000 to $150,000 a year per patient. Most Canadians cannot afford a $150,000 therapy per year. So you can imagine myself going to governments and saying, well, why wouldn't you just cover this? It's very costly. And like most rare diseases, we didn't have robust evidence in their eyes. And we were calling it COPD. I keep going back to that.
And again. Yeah.
So if you are a health minister and I'm coming to you to say, I would like you to provide approval for Canadian Blood Services to provide this very costly therapy for Alpha-1, and it's genetic COPD. All they hear is COPD.
Gosh, it's COPD.
Right.
Exactly. And then they see, whoa, $100,000 times. Whoa, no, that's...
They say, no way.
No way, absolutely. And I can see. But how did you change their mind about this in that journey, Angela?
It took many years.
Yeah.
So it goes back to, how do we change a stigma? And it was around reframing the narrative. So historically, we always thought by saying genetic COPD, decision makers would understand. They don't. These are not healthcare professionals at the health minister level. They just aren't, right? They're decision makers that are accountable to taxpayer dollars, and they see a large price tag on a therapy with a small amount of patients. So they immediately say no. So it was changing the narrative, referring to it as a replacement therapy for a blood disorder, which it is.
Okay, yeah, it
is.
And
it manifests as a lung disease.
Okay.
But the protein is missing in the blood, hence it should be provided by the nation's blood operators. That's where this therapy belongs. It belongs with Hema Quebec, it belongs with the Canadian Blood Services. which means it should be equitable to all Canadians because it is a blood plasma replacement therapy. That's how
great. That's great. Okay, it's just, and it show that's all. That's a decade of work, which is fantastic, by the way. That's extremely fast. But you were able to do that as a champion, and that's a very good example for the public out there. When you get committed to something and you work with the right people, because I'm sure there was a lot of people working with you where you didn't have the science, where you didn't have this, that you work, okay, very, very much. And in terms of the organization now, is there something that have changed in the organization? Because at the beginning you say, oh, let's work together now, okay? And that's another thing that you've changed.
Yes, I have worked with many stakeholders. I have to give a lot of credit to everyone at Canadian Blood Services who really believed in this at the beginning. When I went to their executive management and their board, confused to why Alpha-1 was being held at a different standard than all the other
Their
diseases,
blood
right?
disease.
Why are we being treated differently? It was because of the stigma attached to it, right? With emphysema and COPD. So it was reframing that discussion. So we continue to do that as an organization and by working with the likes of the Canadian Thoracic Society and developing tools with CTS and Canadian Blood Services, not just to educate patients, but to educate clinicians, right?
Wow,
so there
absolutely.
there has been a learning curve here, and it actually is quite timely that the new guidelines were just released, because this is respiratory community has never prescribed to the blood system.
Mm-hmm.
So there are physicians that need to learn how to do that. It's quite simple. It's really quite simple. But because they haven't done it, there is a resistance to change, right? But we've worked with CTS, Canadian Thoracic Society, and Canadian Blood Services to develop tools and resources to help clinicians and their team easily submit to CBS to get approval for their patients. And I'm happy to say that we are well over 420 patients now being approved from.
Wow.
We're not even at a year mark yet. We should be over 500 patients, but we're getting there slowly. But the slowness isn't the patients, it is the physicians. And I'm hopeful that by working with your colleagues across the country that we can start shifting and getting that testing done and getting those submissions to Canadian Blood Services.
That's fantastic. Okay. And I think obviously physicians have to be aware. We have to change the belief. This Canadian Thoracic Society with the new guideline, and now you're talking about these tools to facilitate their work. What is it about the tool for the patient, the resources and the patient support? Because there are patients out there that are listening to you and they say, oh my gosh, okay, I know someone, or I have COPD and I've never been tested. But what are the tools out there, okay, that the patient could be using or being supported if they know they have Alpha-1 Antitrypsin Deficiency?
You are a patient listening and you have been diagnosed with COPD and you have not had an Alpha-1 blood test. I beg you to ask to have an Alpha-1 blood test just to assess what your serum level is at. If you have been diagnosed with asthma and you find that your symptoms aren't really being managed the way you would like with your current treatment, ask for an Alpha-1 blood test. These are really simple things that patients can do immediately. And I need to say, Jean, that you don't need a respirologist to order that blood test. A GP can order that blood test.
Absolutely.
So
it's available. Absolutely. That's a good point to make.
Yeah. You don't have to wait for your annual visit with your respirologist in a year from now. You can ask your GP now for that blood test. So I think that's really key. And I think for physicians, I would like, between my organization and the Canadian Thoracic Society, to get those new guidelines in their hands. To visit either the Canadian Thoracic Society's landing page, their main page has the guidelines.
Yeah.
Visiting alphanetcanada.ca, we certainly have all of the information there for patients and physicians. But I think that is the most important piece, to rule it out. And by continuing to have those conversations, and for any Alpha-1 patient listening, if you're confused or reluctant on how to talk to your family about family screening, please reach out to us and we can provide that support and guidance. There has long been this uncomfortable guilt and shame to share the
About, yeah.
diagnosis. And we need to talk through that piece. I speak to patients all of the time who were diagnosed and are fearful to tell their adult children who are family planning and want to have children of their own because they know it's a genetic disease, and they carry around a lot of shame with that.
Yeah.
So we need to have those conversations, but it is treatable. And there is access now. So the conversation is very different that we're having in 2025 than we were having 10 years ago. And I'm hopeful that with access, that stigma now is becoming less. And that's why it's so important to spread the word and create awareness that there is access. This isn't something you have to be afraid of being diagnosed with anymore.
And advocacy is still very important.
Very
where the
important.
goal will be to change the stigma, and that is presented still in the medical community, in the public, but and then this is what your organization and the role and working with the Canadian Thoracic Society, that you've already changed a lot, and now you think the fact that it's linked to a blood product or organization, it's going to make kind of this disease look different.
I think, yes, I think it will. It changes the conversation, right? I think, most Canadians are familiar with their national blood operators. They know Canadian Blood Services is a trusted organization, the same with Hema Quebec. So when access is provided by our blood operators, there's a comfort level with patients. It's not this unknown high cost therapy that governments are debating about. Governments have now said, we recognize this. We recognize that this is the only specific treatment for this. So there's a different, dare I say, credibility that exists that wasn't there before, because we have the support from health ministers and blood operators and the physician community. So it's really important moving forward that we stress early detection leads to better outcomes.
Absolutely. Early detection, early treatment. If you're a smoker, obviously, emphasize would have to be on that. Smoke-free environment could be the type of work you're doing also. There are certain things in the environment that we're not changing so much, pollution and all of that. There's a limit to what we can change. And the treatment of the disease, because it's asthma, COPD, there are other treatments. But what people have to understand, if you have these disease, you should have the blood test. If the blood test show that you have Alpha-1 Antitrypsin Deficiency on the top of the other treatment that people that have these disease will have, and you will be a candidate for augmentation therapy. And that treatment will prevent you from an accelerated damage to your lung, decline in your lung function, premature death, and or ending up into lung transplant.
Yes. In the last 9 years, I have sadly gone to a lot of funerals of patients who I have gotten to know, and they rely on the patient organization because no one really understands this, right? They rely on us because we understand the disease, and they were grasping for some type of treatment and couldn't get it. And then when it finally became available, they were so sick or already listed for transplant that they wouldn't benefit from it. So this is why I can't stress early detection and access to therapy as soon as possible for Canadian patients. I really hope that that's the takeaway from today.
That would be your call to action.
Absolutely.
Would it be?
Absolutely. Simple blood tests can be done anywhere in Canada. And if someone is confused about where they should go or what they should ask for, or if they some critical feedback from their physician,
not certain.
Please contact our organization, and I would be delighted to advocate on any patient's behalf to ensure that that blood test is done.
We are going to provide at the end of this podcast where this organization, the electronic link, you're going to have phone number. All of that information will be provided for people that that you can reach to these organizations. The same thing for the healthcare professional. Obviously, there's going to be, hopefully, but a lot in the years to come, from the Canadian Thoracic Society to family physician to specialists, also to even educator, because there's a lot of educator out there in asthma, COPD, bronchiectasis, where these educators have to know also about this. Early diagnosis, simple tests. If you have the deficiency, on the top of all the treatment you may have, augmentation therapy. Now there is an access across the country where you can have these treatment. This is a call to action to prevent that you're going to go to as many funeral that you've been going in the years, okay? As many sad story that you could tell about patient who end up with a lung transplant at best, and many of them didn't even have that chance and had premature death. Then it is not about COPD, it is not about asthma, it is about a genetic disease that we have to recognize, and there is a treatment and there is access now.
I mean, we need to stop that, and we need to have those conversations. We in the patient community need to continue to have those conversations. And I think it's important in the clinic to also have those conversations, because that is the only way to work to reducing the stigma, is to kind of work through that perceived shame that someone may have.
Angela, thank you very much for this the very positive message. You've been a very good example of someone who can work and change something. We can change something. You've done that for us as a respirologist, and to all the patients who have this condition. Please stay with us. Continue to work with your organization, with us, and it is together that we can keep making the difference. That's just the beginning. Thank you so much.
Thank you, Jean, and thank you for all of your support throughout the years. It's meant a lot to both myself and the patient community, so thank you so much.
Thanks for listening to the Expand podcast. Stay tuned and listen to other episodes on chroniclungdiseases.com/podcast.